All right. Now we should see people coming in. Sorry to keep everyone waiting. Welcome, champions. So we're just going to wait a moment while people get in. We've got 16 participants, 17, 18. We'll give everyone a few minutes to get into the room, Doctor.
Yep, I'm ready. No problem.
I think we have a pretty large crew today, so we're going to keep everyone's phones quiet. All right, it looks like just about everyone is in. Good afternoon, everyone. My name is David Hiltz. I am your host for our monthly Champions webinar on behalf of the Citizen CPR Foundation and myself, as well as our guests. I welcome you. As a reminder, your microphones will be muted. So please use the chat function of Zoom to log your questions, of which I hope there are many. And let's go ahead and get underway. I received no announcements from the group, so therefore I will only make one announcement, and that is don't miss out on next month's champion webinar. We do not have the subject and guest locked down as of yet, but plan to do so in the fairly near future. So no announcements today. Today, I am very pleased to introduce our guest, Dr. Roger White from Minnesota, who is exceptionally well versed in resuscitation, is exceptionally well known throughout the resuscitation community. And, you know, I was thinking about law enforcement defibrillation as a key focus area for us all this month. And it didn't take me very long to think of Dr. Roger White as the person to reach out to have as our featured guest. In addition to the good Dr. White, I've got a couple of other people in the audience who we may call upon later on in the webinar to provide us with some reaffirmation and feedback. Dr. White has received, among other things, I'm not going to belabor the point, but he's been the recipient of the Hans Dahl Award through the Citizen CPR Foundation. He's been recognized by ILCOR, and outside of that, he's all around great guy, and I'm so pleased that he's with us this afternoon. So, Dr. White, if you wouldn't mind, could you tell us a little bit about yourself and how did you get involved in resuscitation?
Well, thank you, David. It's interesting in looking back on this, how it all started. When I was in medical school, I always had an interest in cardiac arrest and resuscitation. So when I joined the staff of the Mayo Clinic, I went to the private ambulance service that was providing the service in this city and told them that I would volunteer as their medical director. I immediately began to respond with my own equipped vehicle to as many cardiac arrest calls as I could, primarily, admittedly, to provide the paramedics with medical direction. But I must say, in doing that, I learned a great deal more about cardiac arrest and resuscitation. So that's how it all kind of evolved from that experience.
Thank you, doctor. And I'm not surprised by your response. Now I'm gonna ask because it's not often that we have an opportunity to kind of learn kind of really neat things about people like yourself. But like, was there one particular experience or arrest or event during those early days that just had a profound impact on your involvement with resuscitation? Was there something that really just stands out more than anything else?
Prior to my bringing police aboard to do resuscitations or to help us with resuscitations, I was always aware that unless we could get patients in VF defibrillated quickly, we were not likely to have a favorable outcome. So when we did get there early enough, we did well. But there were so many times in my memory where patients in VF did not survive. And that awareness prompted my thinking that we could be doing something differently. And we went on to bring the police department aboard in 1991 to see if the addition of those people could influence survival by cutting the times to defibrillation.
Interesting. Now, correct me if I'm wrong, but in your area of Minnesota, the police had played a pivotal role in pre-hospital care prior to 1991. Is that correct?
Yeah, that is correct. And what role they played was this: they provided CPR for cardiac arrest patients and would await the arrival of the paramedics with a defibrillator. And then they would see the potential for an outcome if they were so equipped. So they knew they were in a holding operation, doing CPR, awaiting the arrival of a defibrillator. And that kind of stuck in their thinking that maybe they could be doing that too. There didn't seem to be that much of a challenge to operating a defibrillator. So that was an impetus that I could build upon to bring them aboard to provide defibrillation as well as CPR.
Very good. I've got another question that I'm like dying to ask right now, but I'm going to put it off until later. So, Dr. White, since we're focusing our conversation on law enforcement strategies to reduce time to first shock, you talked about the time-sensitive nature of defibrillation in order for it to be effective. Can you give us a brief overview of the supporting evidence and science? And what I'd like to do is, like, let's make pretend that you and I are at a very nice place and perhaps having an adult beverage, and 30 or so other people on the webinar are kind of listening to us have a casual discussion. So, I'd say, so Dr. White, it's really great to be with you this afternoon. So tell me how strong is the science and the evidence behind equipping law enforcement officers with a life-saving tool in the form of an automated external defibrillator? Does the science make sense, or can you help me out here?
From the very beginning of our bringing police aboard, my obsession, I would call it, was to make measurements that would show that we were either making progress or we weren't. And I told the police department at the outset, if I could not show with objective measurements that the addition of their personnel to our program was not making a difference, then after 2 years, I would bring it to an end. So during that 2-year period, I began immediately to make measurements. And the most critical measurement I made was the time interval between the receipt of the 911 call and the delivery of a shock. And in 1994, I published my first paper on measurement of critical time intervals in determining patient outcome. That paper was published in Annals of Emergency Medicine. And the whole paper was based upon the science of showing that if you make measurements of the time from call receipt to shock delivery, you could make an impact on survival. So that was the first step. Then that was 1994. And believing that it was going to work, we continued it beyond those 2 years. In 1996, we published again and showed yet again that the time interval was critical as a determinant of survival. Then we looked at our data in 203 patients after that, looked at those who survived and those who did not after a bystander witnessed arrest. And yet again, we showed persuasively that that time interval between call to shock was a major determinant of survival. So we were, from the very beginning of this project, invoking science to show us whether or not what we were doing was making any difference. And that's been the strategy that we have followed from day one to today. Make measurements. See if those measurements show that it works. And if they don't, then you better do something different.
Sage advice. That's exceptional. Now, it seems to me, so this has been an area of fancy for myself, the concept of law enforcement defibrillation strategies. It seems to me that there was some evidence that was less than supporting for some circumstances. And pardon me for not being able to provide the citation, but I believe there were some reasonably well-powered studies that indicated that perhaps in some urban settings, that equipping law enforcement with defibrillators didn't improve neurologically intact survival. Did I dream this, or is there some contradictory evidence?
No, I think you're entirely correct. Early on, after we launched the sole concept of police defibrillation, others opted to take a look at it in their locations as well. And there were a few studies that were negative. And I applaud those investigators because they were honest. They were making the measurements that we were, and they were showing that it wasn't working. And it wasn't working primarily because the police were not being dispatched quickly enough to reach the patients who would have been recipients and beneficiaries of early defibrillation. Unless that time interval is as short as possible, police defibrillation or any other defibrillation isn't going to make any difference whatsoever. And those people were honest to acknowledge that and to get it published. That was an eye-opener, and people needed to know that. And they still need to know that, because I am convinced that unless you measure what you're doing, you don't know where you're at.
Very good. That message rings through loud and clear. So it seems that there's some excellent quality evidence supporting the concept of law enforcement defibrillation strategies. Good news to the audience. Dr. White shared, and his assistant shared, a very nice presentation that we've put out on a slide sharing site, and we will provide you with access to those slides along with some other additional resources after today's webinar. So certainly appreciate that. Now, Dr. White, again, carrying on our informal conversation, although we've got lots of witnesses and we're doing this in cyberspace, could you tell me, if I'm going home, we're gonna finish up our adult beverages here shortly, and I'm gonna go home and I'm gonna, knock on the door of my local police department that may or may not have, what they believe to be, an early defibrillation strategy. Could you give me a sense for what the absolute best practices are for what we might call a high-performing law enforcement defibrillation program? What do you think those tenets are?
You've used a phrase that that really rings in my ear. You said high performing. And I want to capitalize our thinking a little bit on that. First of all, it's obviously groundwork that the police department commit themselves to doing this. They have to believe in it. And somebody in the police department administration, in our case, it was always the deputy chief of police, who was the one who guided the thinking and the impetus within the department to take this on and to give it a try. So somebody in the police department has to make that commitment. The second thing that I want to emphasize that's unfortunately so poorly appreciated is that there should be, in my opinion, there must be a physician who is also, like the police department, committed to this initiative. And by commitment, I mean that physician, medical director of the defibrillation program, will take it upon himself or herself to acquire the data from every event, to analyze it carefully, to meet with the police officers on a basis as needed to review the events. But here's where the high performing thing comes in. Unless the medical director and his or her associates commit themselves to publishing the experience, the data, they won't know and we won't know whether police department defibrillation in their location makes any difference at all. Wouldn't you want to know that? I mean, if you're making an expenditure to do this time and effort and money to provide this intervention, you want to know whether or not it's proving itself to be effective. And how do you prove that? Well, you have to measure the outcomes. How are patients doing? Are they surviving? And are they surviving in a sufficient number to warrant, to justify, to defend what you're doing? It's, to me, and I'm making a very personal point here, very disappointing that so very few police departments in this country have ever taken it upon themselves to publish their patient experience. And we are sorely lacking in knowing exactly what law enforcement is doing with provision of early defibrillation. That's a sticking point with me because we started out making that a major objective, and I think every police department that takes this on should make that commitment as well.
Well, Dr. White, thank you for being so personal with your commentary there. And for me, it puts it casts transparency in a different light, right? In this age of transparency, perhaps police departments should be transparent with how they're doing with efforts to save citizens' lives, right? I really appreciate that. And I'm thinking, my mind is rolling back to some of the earlier days where we looked at the anatomy of a sudden cardiac arrest response and what a critical difference a minute or two can make, and how in many environments and communities law enforcement can have a really significant impact on that. Drop to shock time, it's absolutely remarkable. I have a little bit of a personal question before I move on. Uh, Frank Pantridge, was he an influence on you at all, or am I going down an unbeaten path here?
Partridge was he was a true pioneer in provision of early defibrillation, because he put his little defibrillator in the ambulances in Ireland and himself went with them to see whether it would make any difference. He was primarily interested in seeing whether his little defibrillator was going to be effective. At the same time, though, of course, he wanted to see whether getting there quickly enough was going to make any difference. And he did. And he published some very early evidence that provision of early defibrillation was going to work. And his device proved itself to be very effective in enabling that to happen. So I always embraced Frank Partridge's work. He stimulated me to take this on and look at a whole array of different defibrillators in our experience to see what would work best in our setting.
Thank you for that. And it's clear, as in most things related to resuscitation care, particularly when it's involving professionals, it seems that among the necessary ingredients, training, protocols, devices, physician champion seems to be kind of an essential element to having a high performing plan for law enforcement. Would you mind expanding on that a little bit, Doctor?
Well, I'll go back to the phrase that you used a little bit earlier, and I've used it, and I want to use it again. If you
Please.
talk about a high performing police department, how do you know it's high performing? What is your measurement to enable you to say, we have a high performing police department? Well, what is an outcome that you can measure to show that it is truly high performing? That's how the patients that you treat are doing. And so I go back to this whole idea that you have to measure what you're doing before you can call yourself high performing. And I always look at how patients fare. And are we doing enough to make a difference? It isn't enough just to use the phrase, we saved a life. That's inadequate today. We live in an evidence-based medical climate where we have to show that we are making a difference in what we are doing. And so that's what I mean by high-performing police defibrillation systems. You measure, you use the tools of measurement that are needed, and then your medical director or assistant or whoever puts the data together, submits it to a peer-reviewed journal, and then we can say, yeah, they are performing well. We could call them high performing. Or conversely, their experience was not what we expected or they expected, and why not?
Yeah, do we need to adjust something?
Yes.
Could it be something as simple as where we're keeping the devices in the cruisers? So interesting. We talked about physician champions on at least 2 occasions here. Now, you were pretty fortunate to have a strong champion who was also involved with the Rochester, Minnesota Police Department. And I hope I'm not putting you on the spot and asking. You don't need to mention his name, but I suspect that that relationship may have provided a significant accelerant to the progress that was recognized and the success that was recognized in Rochester. Would you mind taking a moment to address that?
At the very beginning of our program, there was a physician here at Mayo who came to me and said, do you think we could be getting defibrillation quicker to patients than we are doing now? And that awoke in my thinking why police who are out there moving on the street 24 hours a day, let's give them a try. That's what I said earlier. We'll give it a 2-year try and see whether or not we can show that it makes any difference. In fact, in that first study, which I referred to, published in 1994 in Annals of Emergency Medicine, we had only 14 patients, but 10 of them survived. That wasn't really my primary interest because I was, as I said earlier, I was interested in the time intervals. What could we measure that would show that we might make a difference? But then that was the building block upon which we built this thing that went from 2 years to now to 2020. That was a physician who helped me, who stimulated me. But I will tell you this, within the police department, it was the deputy chief of police for many years who was a major, major influence and stimulus on me to drive this thing forward. And he more than anyone else influenced where our police defibrillation program went in terms of its survival and our measurement of outcomes.
Yeah, thank you, Doctor, for sharing that. And you know, it's interesting that we talk about the physician champion when we talk about the officer champion, right, or the law enforcement champion, and how they make a formidable pair in moving the concept forward. And I will say that the same individual, Steve, had a significant impact on my own experience and my own attitudes towards law enforcement defibrillation when I was working for the American Heart Association at the time in Framingham, and I picked up the phone and hi, this is Steve from Rochester, Minnesota Police Department. I just read an article in the Boston Globe about the Reading Police Department's decision to remove defibrillators from their cruisers because they found them of no use, including one instance where they had applied the defibrillator to a dead dog without any results. True story. But I think that, you know, the two of you were really made quite a pair, and that, you know, a formidable force to move the concept forward. So I think you are blessed. Mallory, I'm going to ask a favor from you, if I could. Would it be possible for you to unmute both Brian's microphones? That would be Brian Howard from King County and Brian from Coon Rapids. Would it be possible for you to enable them to speak?
Yes, they both should now
Thank
have
you.
permission.
So Brian and Brian, and they both have the same unusual spelling of their first name, which I think is unusual. But in any event, I'm gonna call on Brian from Coon Rapids first to to make a few comments about this discussion thus far. And, you know, being a law enforcement officer, you know, give us your statement of reaffirmation.
Well, free, you know, I charge an hourly fee, David.
I can't afford you.
I really do appreciate you having us, and I really do appreciate the topic today. Doctor, I'd like to thank you personally for, you know, for being a part of this. You're kind of a legend in our circle with that emphasis on law enforcement. A couple things that you said that I took note of. You know, I really appreciated the fact that you addressed that time to shock, and then the fact that you addressed the urban environments. And you know, the majority of the United States lives in either suburban or rural areas where time to shock is really critical. And what we found at my agency is, you know, equipping every police car with an AED shaves literally minutes off of time to shock. There's just, you know, it's a matter of simple mathematics. There's, quite frankly, a lot more of us out there. We get there a heck of a lot quicker. And if you were to put a cop car up against an ambulance or a fire truck in a race, we're going to win. And we can get there in significant numbers where we can be doing that high performance CPR. We can be administering the AED and really kind of laying the groundwork for the ALS. We'll pick up the BLS load with defibrillation and proper CPR. So that way, when the medics get there and the ALS folks get there, they don't have to start that process from scratch. So I know that, you know, in our agency, we just got AEDs in 2012. Before that, it was, why do we need them? We have a full-time fire department, or the ambulance will be there. And I know that I'll tell you that within 4 hours of getting those AEDs, our agency got its first ever law enforcement exclusive save. So saves now with law enforcement are not the exception. They're the norm. We expect them when we get there and a patient's in a shockable rhythm. We expect to get them back before ALS gets there. And we're kind of pissed off if we don't. So you really shifted an entire mindset by giving us that tool. And that simple little tool in our squad cars was all the difference in the world. And it's the thing that we needed. Before that, it was get there and poke them with a stick and tell them to hang on until the real help got there. But that simple AED in our squad car truly empowers us to get those people back minutes before, you know, we were used to AEDs getting there.
So Brian, I have two follow-ups. There's some catchy phrase that I associate with you, something about don't wait, be something like that. What's your phrase?
Well, so yeah, the phrase is don't wait for the help, be the help. So, you know, part of the program that I run in Coon Rapids, HEARTSafe Coon Rapids, is to empower the general public as well. You could have the best trained law enforcement agency in the world. You could have the sharpest paramedics, the best fire department, and the world-renowned hospital right in your backyard. But in those 3 or 4 or 5 minutes it's going to take for the cops to get there, and those 5 or 6 minutes it's going to take for fire to get there, or those 7 or 8 minutes it's going to take for the ambulance to get there, we're already 2 or 3 minutes too late to the party. So what we really teach is the public, if anything, just do the CPR. Keep pumping the pump, keep that oxygen to the brain to give us something to work with when we get there. So don't wait for us. Everyone thinks, you know, 4 minutes is a great response time, but in reality, 4 minutes, you're a minute too late to the party. So if they're just pumping the pump, then all of the technology and tools and techniques that we use can be effective. If they're just relying on us and waiting, you know, they may as well start planning that funeral, because we just can't get there in enough time. There's a study some time ago put out that said 97% of the patients who die while waiting for the help, which means the glaring deficiency there is they weren't receiving the help before the help got there. So
Well
it's
stated.
not just one magic bullet. It's a layered approach, and it starts with the bystander and filters up to the police. And, you know, what I say is, what you do while you're waiting for the cops is setting the table for the cops. What the cops do is setting the table for the fire. If you have that fire department with ALS skills, is setting the table for the paramedics, and each person's getting that patient in better condition, in better shape. So when the hospital does get them, it's It's not a corpse. It's a living thing that can be saved.
Thank you, Brian. And in case any of you were wondering, if I didn't like hold Brian back, he'd take the show for the next 20 minutes. Brian, thanks for that. Now tell me one thing, and by the way, I think it's really interesting that HEARTSafe campaign can be led by a law enforcement agency rather than, you know, a fire department, ambulance service, etc. Brian, before I get to Brian Howard, Brian, what did it feel like the first time you pushed the shock button with an AED hooked up to a real person?
You know, I'll tell you what, Dave, talk about a leading question. The first time I ever pushed that shock button was in November 2012, and it was a fellow named Tim Hoffman. And I'll be honest with you, the first time I pushed it, I was a little bit frightened. Didn't quite know what to expect. And it far surpassed my expectations, because a minute after pushing the button, there was a living, breathing guy back. And again, his name was Tim. And I say that you meet friends in the strangest ways in life. And I just happened to meet Tim sleeping on the job, because his cardiac arrest was at work. And we have been thick as thieves and good friends ever since. So what a good feeling. And for law enforcement in general, for a career that likes to be villainized, we really do sincerely get into this line of work to genuinely help people. One of the frustrating things about being a police officer, you know, the first 15 years of my career was we were helpless. We were as helpless as those families at that cardiac arrest scene. We were just as helpless. We weren't equipped until our chief in 2012 decided to put those AEDs in there. All of a sudden we get those AEDs and we're inspired, and we're motivated, and we're getting in there, not just hoping for the best, but we're getting into that house and we're expecting results. We're expecting to save that person, particularly on a witnessed arrest. And that's,
Perfect.
you know, the impressive thing to me is we're coming in numbers. We're getting 3 or 4 cops in there, and we're getting the job done because now we're equipped to do the job. Don't send us into a bank robbery with a squirt gun. So don't send us into a cardiac arrest without the tools to do the job.
Excellent. Excellent, Brian. Thank you. Hey, Brian Howard from King County Sheriff's. So glad you could join us this afternoon. I'm going to begin by asking you, Brian, if you might reflect a little bit on, you know, what Dr. White and I and the other Brian have commented. Tell us a little bit about your department's experience and, you know, what sage advice you would give our audience this afternoon.
Sure. Can you hear me okay?
Yes, if you could get closer to the mic, that would be even better.
All right. Well, thanks for having me here today and being able to share some of my observations in our agency. I come from a sheriff's department that services 2.2 million residents. We have 750 commissioned officers that work in 13 cities, 2 transit agencies, and an Indian tribe. So we're a very diverse department. We service rural and very urban and suburban communities. And one of the points I'd like to make is our prediction was that we'd have a higher success rate in more rural areas where fire departments were predominantly volunteer or combination, and we might have a better response time. And I was wrong. We've had just as many saves in our urban areas, and it really boils down to the fact that police officers are out driving around, and so there's not a turnout time that delays response, and that allows us to arrive at these calls quicker. So we've had some great saves in very urban environments as well as rural neighborhoods. I do agree that we need to measure our success, and we need to look at the data and be data driven. We looked at response times in first positioned AEDs in the slower response areas. That's how we rolled out from an initial deployment of 53 AEDs to today we have 486 AEDs. We're currently downloading 2 AEDs a week that have been used in the field, and I think we're running around at 8 to 10 shocks per year. So very good success in the program. One thing that we noticed early on was the importance of fixing the dispatch. And I heard Dr. White talk about the importance of timely dispatch. We have some neighboring agencies that don't dispatch their officers to AED calls, but they just expect officers to maybe stumble across cardiac emergencies. We went the other way. We tone our AED calls out, just like we do a bank robbery or a shooting, and we expect our officers to respond with urgency. And I think that was a huge determining factor in some of our successful shocks and saves. We also recognize that this is a team effort. We approach it that way. We train our dispatchers, our 911 call takers, and our officers to work together. And even if they arrive at an AED call and the fire department's already there, it's a team effort. And our officers are trained to go in, join in the Congo line, help with compressions, move furniture, provide better access for the medics who might be arriving. You know, it's not just from our point of view trying to get there first, but it's trying to be part of a successful save. And we reiterate that. Yeah. With our recognition program, we have an awards program, and we recognize our dispatchers and 911 call takers right alongside the officers, because they're just as important to the success of the program as the officer that responds.
Yeah, couldn't agree more, Brian. And thanks for sharing your reaffirming statements and more. And couldn't agree with you anymore that, you know, resuscitation is a team sport. And I think that, you know, that could actually be a discussion for another day, but how to do effective multi-agency debriefing in an effective manner. So I might be reaching out to you to learn a little bit more about that. So thank you, you two. By way of disclosure, Brian from Coon Rapids is one of our program advisory committee members, and also serves on the Take Heart America group as well. So thanks, both of you. Before we open it up to questions from the audience, what are your top 3 recommendations, Dr. White, for all of us as we, you know, open it up to questions and answers? 3 things. We leave. What are the 3 things we need to do to champion this?
Sure. Number one follows from what I've been saying all along here, and that is, if you don't have a police department that is committed to this sort of initiative, you aren't going to get anywhere. You need their commitment, and I mean visible, audible commitment. And you also need that physician director that I talked about earlier, who also is going to make a similar commitment. Another thing is, how is the community today going to respond to police officers in the climate in which we now live with all the tumult about police? How is the community going to respond to their presence when they arrive in a home? So the community has to have confidence that a arriving police officer is a friend and not a foe. And thirdly, the EMS community itself has to embrace police officers, must include them as legitimate, helpful first responders. So those 3 things collectively are mandatory if a program like this is ever going to succeed and provide objective measurements showing that what they are doing is working. I say that over and over again because that's how I believe, that's how I think. We have to know what we're doing.
Excellent. Thank you, Doctor. Mallory, we're going to be tight on time here in a few minutes. So would you mind facilitating the questions and hopefully answers period?
Absolutely. So we have our first question came in, and it's for the Bryans, which you should still have speaking abilities. If you wear body cameras, do you shut them off to protect patient privacy when on arrest calls?
Interesting question.
So this is Brian from King County in Seattle, Washington. We don't have body cams. We're doing a pilot project right now. And our policy will state that in general, cameras stay on, but then we have very strong redaction rules and would never release anything that could potentially be a HIPAA issue. So,
Well stated.
Yeah,
Brian?
Brian from Coon Rapids, same exact answer. We do not have body cameras yet. They are coming. We do have microphones that we wear into all the calls, and they're to stay running at all times. But again, things will be redacted if it's a matter of releasing to the public for HIPAA reasons.
Excellent. Mallory, the next question, please.
Besides cost, what is the biggest reservation of a police department in adapting a Defib program?
Brian from Coon Rapids, if you don't mind, the biggest reservation is the officers themselves. The biggest thing is to get the officer buy-in. It's one more thing that we have to carry, one more thing we need to do. Until they see it firsthand and they realize how easy it is, we're cops. We're hesitant to do new things. We fear change. So really, it's the buy-in from the officers and to get the officers enthusiastic about it. But that's where the recognition thing comes in. I like what King County does. We do the same thing, is recognize not only the officers but the citizens involved, the dispatchers, the firefighters, the medics, and we also take it a step further to do a meet the rescuer ceremony, or not a ceremony but an event. It's a lot of times the big question for officers is, I wonder if that guy lived. So it's as good for our souls to meet the people that we saved than it is for the families to meet the people that saved them. Once you meet a person and you meet that person's wife and that person's kids and their dog and their grandma and their grandpa, you realize the effect that you've not only had on that person. You didn't just save that person, you've saved that entire family. So once these officers started getting these saves, you want to go and get more because you realize the power that you have out there. And if we have the proper tools, we want to go and get the job done.
Bravo. Exceptionally well stated. Very good. Mallory, additional questions?
Yep. Dr. White, do very many police departments seek your advice in setting up and managing police AED programs?
Several years ago, that kind of call was quite frequent. It hasn't been for the last several years. And I suppose in a way I'm disappointed in that, because if I were called now, I would be making the same points I made earlier. If you're going to do this, plan to set it up, to gather data to show what you're doing. And I think that might be a bit of a deterrent for some who just say, let's go out there and save lives. And I just don't buy into that anymore, nor have I ever. I always want to know what we're doing, and I expect police departments to be doing the same thing. Know what you are doing, measure it. And if it's working, great. Then go ahead and publish. If it's not working, go ahead and publish so that we can all share your experiences and learn from them. But we'll never know that unless people gather the data, analyze it, and report it.
Excellent. Excellent response. We may have time for one more question, Mallory.
Okay, we just got another one. Are there guidelines and our program advice available from police or medical organizations for these programs?
So I'll take that one if you'd like, Dr. White. So,
Yeah.
I'd say that, there's a number of excellent resources out there. We're going to provide those to all of you after the call. That's a benefit of registering, is that we can send you an email with content afterwards. But I haven't looked at the list of participants today, but I'm pretty certain there's at least a couple that participated on this National Center for Early Defibrillation Task Force on Law Enforcement Defibrillation. And they came up with 2 documents, one of which was the 10 pieces of best practice for starting a law enforcement defibrillation strategy. And it was published in the journal PEC, Pre-Hospital Emergency Care. And, you know, I think that although there's been some science changes and things of that nature since the publication of that paper, that still remains my go-to for any department that's looking to establish a high-performing law enforcement defibrillation program. And it's our plan to circulate that along with a number of other resources after this. Additionally, the Resuscitation Academy in Seattle has some excellent resources, and many of these you can find in the resource section, you know, under the HEARTSafe tab at Citizen CPR Foundation. So outstanding. We've got a few minutes left. Dr. White, you know, I got to tell you, I'm really, really pleased that you decided to respond to my email and entertain the idea of joining us this afternoon, because I think you are just a true giant in resuscitation. You're a true champion of the cause, and I really couldn't think of anybody better to pair up with Brian and Brian for the benefit of citizens, you know, everywhere throughout the globe. So I'm very, very thankful, and I feel very privileged to have been able to share time with you this afternoon. So
Thank you.
it's my absolute and delightful pleasure, sir. So we always wrap up these champion calls every month with, hey, how are we doing, everyone? So if you wouldn't mind using the chat function, you know, was this good? Was it bad? Was it a waste of your time? Was it spot on? Can't wait for next month. Dave needs to do less talking. Dave needs a haircut. Whatever it is, let us know your feedback now so that we can make the necessary adjustments for next month. So go ahead and take a moment to do that. And then while you're all doing that, this brings us to the conclusion of our Champions webcast for this month. As always, I thank you for your time and, you know, your tireless efforts and everything you do every day to improve outcomes. Until we speak again, thank you, and stay safe and stay healthy.
Thank you.